Okay. Good afternoon, everyone. Certain people, good morning. And I would like to start the session today. I'm Dr. Lily Moshaha. I'm the Deputy Chair for ASEAN, Southeast Asia and Oceania. And with me is the Chair, Professor Talangsak Kanjanambuch. So we will be chairing this session today, where for the ISN OSEA Clinical Pathological Conference. And the team who will be presenting today will be from Thailand, from the King Chulalongkorn Hospital. That's where Professor Kanjanambuch, or we well known him to us as Golf, will present the session. So without further ado, I would like to invite the Thailand team from King Chulalongkorn Hospital to present the case. Please.
Thank you so much, Lily. So, good afternoon and good maybe good evening for some us from Australia, New Zealand, and also Fiji. So, we're gonna spend 1 hour for the case. And my second year fellow, Dr. Natapat, gonna present the case. And today we have a special guest, Dr. Jilasit, who is a pathologist. He will interpret the slide for us. So because we're gonna have another conflict schedule at 12:30. So Natapat, please start your presentation. And also we're gonna upload the case synopsis again into the chat box. So if anyone haven't seen it, so please download from the chat.
Okay, thank you. Good afternoon, everyone. My name is Natapat Aduduang, the second year fellow in King Chulalongkorn Memorial Hospital, and it's my pleasure to present today's case together with my advisors, Professor Talangsak and Dr. Jirasis from our hospital. Before we begin, we would like to thank the ISN OSEA committee for the opportunity to share this case with all of you. Many of you should already have received the case protocol in advance. I hope it gave you a chance to start thinking about the differential diagnosis because we will pausing pathway through today for an open discussion. So please keep your thought ready. I will be inviting volunteers to walk us through their reasoning. With that, let's get started. Okay, our patient is a 70 years old Thai male living in Bangkok, working as a freelancer. History was obtained directly from the patient together with his medical records, so we can consider it reliable. He presented to us with a chief complaint of rising serum creatinine over 4 months prior to the admission. His baseline functional status was excellent. He could perform all basic activity of daily living without limitation. 5 years, he started to notice nocturia, initially just once or twice a night, but gradually increased to 3 or 4 times a night, with daytime urination another 2 to 4 times a day. He wasn't sure exactly how much urine volume that represented at that time, but there was no hematuria, no formiduria, no incomplete voiding, no dysuria, no incontinence, no leg swelling. Everything seems normal and didn't bother him enough. He never sought any medical attention there. So he lost follow-up and take no medication at that time. 4 months prior to the admission, the nocturia was still the same without any fever or weight loss. At that point, he came back to the clinic for his hypertension. His blood pressure that day was 158 over 108, but tests show his creatinine had risen from the baseline 1.0 up to 3.3 milligram per deciliter. But urea nitrogen was 29, and his estimated GFR had fallen to 17.9. He was started on lercanidipine 10 milligrams a day and losartan 15 milligrams a day and referred to us as a nephrologist. 1 month later, 3 months before admission, his creatinine had already worsened further to 4.4 with GFR down to 12.6, and his blood pressure still high, 145 over 94. So the medications were adjusted to the irbesartan 150 milligrams a day, lercanidipine increased to 20 milligrams a day, and folic acid. He had no urinary symptom and no weight loss change at that visit. 2 months before the admission, his home blood pressure reading ranged from 140 to 152 over 93 to 100. And clinic blood pressure was still high, 160. Labs today show hemoglobin about 11.8, creatinine 4.1, which is still high, and urine analysis show the sediment 2+ for protein, 2+ for blood, and red cell about 2 to 3
Dr. Nadapat,
cells for
can
hyperfill.
I interrupt you a while? You should not go into the very detail because
Okay.
you already provide them the synopsis.
Okay, I will go further. And the lab that time shows sub-nephroticrange proteinuria that I showed you PCI 2.5 gram per gram creatinine. And we have a little adjust about medication. We already stopped irbesartan and add sodium bicarbonate. 1 month before the admission, the blood pressure is still high and it seems worsened to 160. And lab is show the worsened proteinuria up to 9 gram per gram creatinine of UPCI. At the admission, the patient denied visual disturbance or any sign of hypertensive emergencies. His urine volume will remain 1 to 2 liters per day, and the lab show worsened creatinine from 3.9 to 7.0 milligram per deciliter for over 2 weeks. So he was admitted for the further evaluation. And past history, he was diagnosed with hypertension 7 years ago and treated with amlodipine 5 milligram per day and losartan 15 milligram per day. He treated for the 2 years and then lost follow-up as I talked before. And about his personal history and social history, he is the former smoker 6-pack years, but quit 20 years ago, otherwise is negative at show. He denied any family history of kidney disease, hematologic disorder, or autoimmune disease, and current medication. His medication list consists of 3 anti-hypertensive medication plus supportive therapy, as shown in the protocol. We move to the physical examination. He was a Thai male, alert, well cooperative, with a BMI of 19. His vital signs show pretty high blood pressure, about 173/96, with no difference among 4 extremities. His skin and appendages was unremarkable. There was no rash at the time, and his ENT showed mildly pale conjunctiva without any eyelid edema or tongue indentation. About chest and cardiovascular examination were unremarkable. Abdomen was soft, no organomegaly and no ascites at the time, no scrotal swelling at a genitalia examination. Musculoskeleton, there was no pitting edema. Lymph node and neurological examination were normal. So in short, it's a fairly unremarkable exam apart from elevated blood pressure and mild pallor. So let's move to the labs. It is about the investigation that I already provide you. His complete blood count show my anemia, hemoglobin 10.5 for a man, and we already work up for the cause of the anemia. The red cell index point to the microcytic as a picture, and we have a reticulocyte count about 61,000, and the rest as shown. And we move to the right side, that's the chemistry side. Kidney function at admission show uremia with a BUN 61 and creatinine 6.9, consistent with the rapid rise I described earlier. And adenomyosis, hypokalemia, and hypoalbuminemia as shown. I move to his urine analysis on admission. Show slightly cloudy urine with sediments that have 3+ protein and red cell were 3 to 5 cells per high power field with a few bacteria. Urine chemistry show high urine albumin creatinine ratio about 6,000 milligram per gram creatinine and UPCI about 10 gram per gram creatinine. And we confirm with 24-hour urine that collect for 4.4 gram over 24 hours, which is a nephrotic-range proteinuria. So this table pull together everything I just walk you through: the renal function, urine analysis, and urine chemistry. Across the same timeline from 5 years before the admission up to the day he was admitted. The trend is important thing to take away here. The creatinine climbed from the baseline of 1.0 to 3.3 to 4.4 and rapidly go to 7.0 0 milligram per deciliter within the last 1 month. And UACR is went together with the creatinine, start from 1.8 gram to 6,000 milligram per gram creatinine at the visit. And this graph plot the same data visually, the serum creatinine over time, and this is inverted, this is the eGFR over time, and lastly is the inverted creatinine over time, which is show the decline accelerated faster than his prior trajectory would predict, and especially the final couple of months. So we sent a fairly complete autoimmune and infectious workup. ANA was negative as well as both C and P ANCA with anti-NPO and anti-PRT and anti-GBM were negative. Serum cryoglobulin and rheumatoid factors were also negative too. Complement level were all within the normal range. Infection workup show prior hepatitis B exposure and negative for anti-hepatitis C virus and anti-HIV. So in short, a clean autoimmune and infectious serology that should already start knowing your differential. And his chest X-ray and ECG and electrocardiogram were both unremarkable. There is no pulmonary edema, no infiltrate at that time. The renal ultrasound show a right kidney of 10 centimeters and the left kidney of 9.5 centimeters, a normal size for his build with a normal echogenicity and preserved cortical thickness in both and a normal urinary bladder. So at this point, I'd like to hand things over to you. So based on everything we have covered, the history, the exam, and the initial workup, I'd like to invite a volunteer to walk us through two things. The first, which investigation would you pursue to attribute the diagnosis? And the second, what is the most likely diagnosis and what do you expect the kidney biopsy to show? I'm just interested, please don't feel you need to have the single right answer. I'm just as interested in how you reason through it.
So for anyone who just joining us, the case synopsis is uploaded in the chat, so you can download that. And who gonna want to be volunteer or start with listing the problem of the cases, and then need any additional workup or test. I know that they review all of serology, but anyone want it more? Something like that. Anyone want to start? So probably I will look at the people who join us. Anyone from Singapore, Vietnam?
Good day. I'm
Okay.
from Vietnam.
Hello, hi Anne. Hello.
Hello. So I'd like to know if you have checked the electrophoresis of protein.
Can you repeat it, hi Anne?
Uh,
Apologize.
I'd like to know if you did already the electrophoresis, protein, blood protein, and urine protein electrophoresis.
Whether any HB electrophoresis were done.
Oh, wonderful. Okay, we ordered that, but haven't get it yet. So we have to keep until we have the pathology first. Do you think that we have to wait until we can do parallel? So do you think that we have to wait until the protein electrophoresis come back, or you just go ahead to doing something or treat the patient first?
There's Adrian from the chat suggests
Okay.
bone marrow biopsy and trephine, Gulf.
Oh, thank you, Adrian. So a case is a 71 years old man with unexplained kidney failure, and the workup is about isolated low C4 anemia and seronegative. I think the patient have a RPGN, right? Because the rapid progress of serum creatinine and dysmorphic red cell and proteinuria, sub-nephrotic range, and become nephrotic range. So we should think about the RPGN and seronegative RPGN. So high-end already said, so we should send protein screening and book. Anyone want to treat first or giving them initial immunosuppressive before doing biopsy, or we have to wait until protein come back? Anyone?
You may not even need a kidney biopsy. I will not even do a kidney biopsy for this, and I would correct. I'm not so sure that you can call this an RPGN. An RPGN means rapidly progressive, and there must be evidence of glomerulonephritis. What you have is a nephrotic range proteinuria. That's not really an RPGN, but you have enough evidence to show that you're dealing with a monoclonal gammopathy. So the fastest way.
No, we don't have that right now.
No,
we don't have that.
no. You have evidence. You have evidence in your clinical presentation. You don't even need to wait for your protein electrophoresis to come back. In fact, the fastest ways to get a diagnosis is to get a bone marrow immediately, and then you will probably find, or if you can get a free light chains, this patient probably will require a clone-directed therapy, and then you can actually not do a kidney biopsy and you only do a kidney biopsy if they fail to respond to a clone-directed therapy.
Well, but usually when the patient with dysmorphic red cell and hematuria, proteinuria, rising of creatinine within a few weeks. So I think we should differential diagnosis of RPGN first. And I think it's
So you have two very important clues. One is that this patient has significant glycosuria in the absence of diabetes. That's already suggesting to you that you have a proximal tubulopathy. Secondly, you have a discordant proteinuria and albuminuria. Your proteinuria is significantly higher than your albuminuria. And this is a gentleman who's about 71. So he actually fits the profile of a paraproteinemia. So sometimes, you could spare the patient a kidney biopsy if you are able to have, investigation that demonstrate a paraproteinemia. So if your lab is able to do a free light chains very fast, so half the time your battle is won, and then you could actually treat without having a kidney biopsy. If not, a bone marrow biopsy is usually very much faster to clinch the diagnosis. My take about RPGN is that I think we just have to be very concerned. RPGN has two components. It's rapidly progressive, and it must be a glomerulonephritis. Very unusually that you get a crescentic RPGN with such a heavy proteinuria. That's very, very unusual, unless this is a overestimate where your creatinine ratio, where your creatinine is significantly much lower in your protein in your urine. But I'm not that convinced this is an RPGN in the sense that this is a glomerulonephritis. The sediment is not active enough for me.
Yeah, wonderful. Anyway, anyway, so most of us was taught crescentic GN in 3 box, RPGN in 3 box by immunofluorescence, but not serology. So you can have a pulse immune with ANCA negative as well, and also 15% of anti-GBM disease have negative anti-GBM and autoimmune antibody.
But not with such a heavy proteinuria. That would be very, very unusual.
Yeah. So in my center, usually for hematologists, he's quite busy. It takes a while and a week to come to the patients. And also immunofixation, it takes a week to come back with the result. So we suspect RPGN at that time. So we conduct kidney biopsy. But when we look back to the ultrasound, the right kidney is smaller than the left kidney and have a discrepancy about 1.5. So we do drop ultrasound first to check the renal artery stenosis. But the case is already done and negative, so we go ahead with kidney biopsy. Thank you anyway. Thank you. Okay. And Nataphat, please go ahead with the kidney biopsy and really check the contraindication, and the case have no absolute contraindication, and we control the blood pressure well and before we perform kidney biopsy.
Okay, so and because we are nephrologists, we have in fact we have both data right now, but we will go for the kidney biopsy first. I would like to give a stage to Dr. Jirasit. He's a renal pathologist taking care of this case and also our teacher. So we will go for the light microscopy first.
Sorry, it was muted. Thank you. Next slide, please. Do I control the pointer, or are you gonna point for me?
Pointer. Okay.
Okay, I'll just start. So we got one core. It's a single core, and it's mostly cortex with 21 glomeruli, of which 4 were globally sclerosed, and we got 3 interlobular arteries. Okay, this is the low power. So it looks pretty bad to me, like a lot of scarring already. And okay, we'll go by compartments, right? So this is one of the glomeruli. It has a cellular crescent, right? The tufts appear kind of hypercellular, but I'm not really sure if it's truly hypercellular or because just the capillaries are compressed by the crescent, and the interstitium next to it will be a little bit infiltrated by lymphocytes and plasma cells, possibly due to the crescentic glomerular injury. Next, please. Next slide, please. Okay, it's another glomerulus with a cellular crescent. Next, please. This one would be a glomerulus too, but it's cut through a cellular crescent, so you can only see the. Could you go back? I wasn't finished yet. Could you go back to the crescent without glomerular capillaries?
This one, right? This one, right?
No. This one. Oh yeah, this one. So this is just a cut that passes through the cellular crescent without any glomerular capillaries. So this is entirely crescent. Next one, please. So I can just keep showing you like crescents in different glomeruli. It's the globs are affected by almost every glomeruli have crescents in it. So this is another one with a cellular crescent. The tufts appear a bit hypercellular. Okay, next please. Another crescent. This is a circumferential. It has a little bit of lobulation to it, and there is interstitial inflammation around this crescent. Okay, next. Now we move on to the PAS. We see the glomerular capillaries a little better. We see the same crescent here. There is, in addition to that, there is mesangial hypercellularity, endocapillary hypercellularity. We even see a little bit of GBM double contour in the middle here. Next, please. Okay, this one is another glomerulus with a cellular crescent, maybe with a little bit of ruptured globin capsula around like 3 o'clock. Next, please. We're moving on to silver stain section. So this one, we can clearly see endocapillary hypercellularity, and there is ruptured GBM here at around 6 o'clock here, and circumferential cellular crescent with segmental GBM duplication. Next, please. Okay, another glomerulus with a cellular crescent, endocapillary hypercellularity at around 6 to 7 o'clock, segmental GBM duplication, mononuclear cell infiltrate around the glomerulus. And very importantly, note that the mesangium is significantly decreased, shows significantly decreased affinity for silver stain. In other words, the mesangium is much less black than usual, suggesting that there is something that is not the mesangial matrix that is being deposited in the mesangium, and that might very well be paraprotein. And that's just another cellular crescent with the Bowman capsule is virtually gone, so a very severe inflammation, right? And there's endocapillary hypercellularity. And we're moving on to the tubular interstitium. We have some CAS here. There is diffuse interstitial inflammation with interstitial edema among these atrophic tubules. The CAS are PS positive, so it's probably not a light chain CAS, because light chain CAS are typically PS negative. So they're more likely to be like hyaline or TAM Horsfall CAS, not light chain. Next, please. And this one is the same cast on H&E stain, not as brightly eosinophilic as the light chain cast, right? And lots of inflammation. The inflammatory cell infiltrate are mononuclear cells, but there are some rare eosinophils, and we see some inflammatory cells within the tubule. So we got some tubulitis at the upper middle. Next. Some other areas, there is a mixed neutrophils and eosinophils as well. Next, please. These tubules, these are necrotic cells that are in the tubular lumens. So there's ATN. Next. And probably the last, not last. Okay. I'd like to draw your attention here. This tubule here, normally you would be able to draw a circle around each tubular profile, but this one is discontinuous. So there is tubulorexis, there is severe tubular injury, and the TBM ruptures. So there is tubulorexis here, together with a lot of interstitial inflammation. Next, please. This is one of the interlobular artery. You can see that the endothelium, normally it would be like right on the wall of the artery. Now it's separated by this intimal edema. Right, next please. So you can see that mucoid substance a little bit, and that's probably under the endothelium. Right, okay, next please. The same artery there, mucoid intimal edema, maybe with a fragment of red blood cell there. The lumen is like narrowed. All right, I think that's the last picture. Thank you.
So we're gonna stop for a while. By the light microscopy, so please give us your differential diagnosis in the chat box. Maybe you can incorporate the clinical as well. The patient have elderly, anemia, low C4, normal C3, negative serology, and light microscopy, as you use. Dr. Gilles just mentioned, is an impingement pattern with 100% of crescentic formation. So please text what is your differential diagnosis right now onto the chat. Okay. So we're gonna wait for 1 more minute. Or anyone want to speak out loud? Is please, you can speak it out loud, or if you prefer to text, so you can text it on the chat box. Oh, no one texts, so probably complicated cases. Okay. Otherwise, Dr. Gilles, please go ahead with the immunofluorescence.
I think that's what our audience is waiting for. the immunofluorescence.
But usually for crescentic like this, so we call crescentic GN, right? With RPGN pattern. So usually we think about the three boxes. So the first one is immune complex. Second is immune, and the third one is anti-GBM, and box number 4. So go ahead. I guide a little bit.
Well, from the pathology perspective, I mean, there are more than that, right? People have reported amyloid with crescent, maybe diabetic nephropathy with crescents, right? All right, so I'll continue with the IF. So IgG is negative. This is just background staining. IgA is also negative. This is just background staining. You see that IgG, the background is stronger than IgA. That's normal because you have more IgG in your blood than IgA. IgM, that is very bright. Usually you have less IgM than IgA, so it should be dimmer. Even in the background should be dimmer, but this one is super bright. So probably there is a lot of IgM in the patient's blood. And the glomerulus here is staining 2+ in the mesangium and capillary loops for IgM. It looks kind of granular, right? It's pretty like a little dot. This is another glomerulus here, 2+ mesangial and capillary wall staining for IgM. Moving on to the complements, both complements are negative, C3 and C1q, and kappa and lambda. Now this is really the giveaway, the key to the diagnosis, right? Kappa in the background is super bright, lambda is dead negative. So there must be lots of lambda in the patient's serum and a lot less lambda in the patient's blood. So there is probably a monoclonal IgM kappa in the patient's blood. And the glomerulus, I think this one is probably a little bit ischemic, probably not that representative. It's staining a little bit for kappa, I'd say like trace or 1+, but lambda is entirely negative. So that's, and the background is much stronger for kappa than for lambda. So, I think that's it.
So how we interpret the kappa staining, because the background tubule is stronger than glomeruli.
Do you want me to answer that, or are you asking the audience?
No, asking you because I'm
most of the
here is a nephrologist.
Okay, I interpret that as the background staining. I think it's real because it implies that there is a lot of IgM and kappa in the patient's blood, and if you look at the background here, like in this glomerulus, it's not as bright as the tubular interstitium. So I think that the granular staining in the glomerulus is real.
Do we need a pronase digestion on paraffin?
In this case, I don't think so. I think it's pretty obvious. Kappa is really strong and lambda is like dead negative.
Okay. So, we're gonna open the floor again. Now, what is your differential diagnosis after you see light microscope, scopy, and also immunofluorescence? And what is, if you think that, and do we actually need EM, or has IF already told us enough? No one. No one.
No, go.
Challenging. Okay, Adrian. Okay.
We already went through this.
Thank you.
No. So that's why I told you the kidney biopsy is absolutely not necessary. I mean, it is not surprising that you get a lot more staining on the tubules because the patient does demonstrate a proximal tubulopathy. You get significant and that's the important part. If you see glycosuria in the absence of diabetes, you must know that this is a tubular involvement. Now, the thing is, you know that this is a monoclonal gammopathy. This is the IgM. You just need to, decide what is the phenotype. And IgM, you could either be a multiple myeloma IgM, or this is a Waldenstrom microglobulinemia. But looking at the kidney function, the kidney biopsy, this is probably a multiple myeloma, and you probably will get away. You probably need a bone marrow.
Yeah, it's good clue though. Besides, if the patient have a SGLT2 on SGLT2, so probably the patient will have a glucosuria. So, but the patient have no
Yes.
SGLT2 inhibitor.
Yes, of course. But I mean, the important part is that in a monoclonal gammopathy, a lot of the times your diagnosis is based on your urine dipstick. And if you see a glycosuria in the absence of anything else, then you know that you're dealing with proximal tubulopathy. But more importantly, in this case, you have a discordance between your proteinuria and albuminuria. So the diagnosis is actually very obvious. In fact, so that's why I say it. In most situations, you could spare the patient a kidney biopsy. If you could get a bone marrow biopsy even faster and start clone-directed therapy, then you could actually watch and see whether the patient respond to the clone-directed therapy. If they do, then you don't need to do the kidney biopsy.
I agree. So because the patient also have the gamma gap as well, serum gamma gap, because the gamma globulin is higher than albumin level.
Oh, you didn't show us that. Did you show us that?
Yeah.
Okay.
You hid that from us, did you?
No. It's the
Oh,
protocol.
it was there. Oh, it's in there. I haven't read it.
Yeah.
Sorry.
Oh, the other thing, just to add on, I mean, to support the multiple myeloma, the other clue like hypercalcemia was not there, isn't it?
Yeah.
For the fellow training, because it didn't like if for us, for example, if we think it's a multiple myeloma or monoclonal gammopathy, to go for a bone marrow biopsy first, we would think at what other parameters that supports like hypercalcemia, hyperuricemia, and maybe the hyperglobulin. But I don't see the globulin. Is it very high? Sorry, Golf. I didn't
Globulin
notice
is
that.
4.4, and albumin is 3.4.
Okay, more than 1 point.
So the criteria for CRAB, which is your hypercalcemia, renal involvement, anemia, and etc., and your bone, that's the criteria for diagnosing multiple myeloma.
Yeah.
So I think just be careful about that, because you
Yes.
do get MGRS without fulfilling the CRAB criteria. But I think the suspicion is always that when you have a discordant proteinuria and albuminuria, or when you have evidence of a proximal tubulopathy in the setting of an AKI, it must scream a monoclonal gammopathy until proven otherwise.
So
and
right now
the best is if you could get a free light chains. That would be the best, because that's about 80 to 90% of the cases.
Yeah.
So right now, so we have two questions for you. Why the patient have isolated low C4, and the crescent is 100% in the light microscope. So usually for monoclonal gammopathy, crescent is less than 20% or 25.
Well, you do have there have been report of crescentic features in MGRS. The other thing is that this is an IgM. I noticed that your rheumatoid factor is negative, your cryo is negative, so that it's also very less likely. There has also been reported of anchor positivity associated with monoclonal gammopathy. There is an entity called PGN-MID, which usually it's a lot more proliferative and it doesn't give you the crescentic kind of features. So, and all your serology is all negative. So, C4 glomerulopathy is also considered one of the classification of MGRS, but I can't remember. I don't think your IMF stained any C4. Did you stain for C4 or no?
No, we routinely stain for C4. We just did the C3 and C1Q.
Okay, so some of the labs, they will stain for C4, but I think, frankly speaking, I think that's all purely academic.
Dr. Jason, please go ahead with EM because we already done that.
Okay, I will go for EM.
Right. So this is a capillary loop. These are the capillary loops on the left-hand side, and you see this powdery deposits on the inner side of the glomerular basement membranes, and you also see these powdery deposits in the mesangium as well. Next, please. Okay, food process effacement, quite severe. Another one, band-like powdery deposits along the inner surface of the glomerular basement membrane with diffuse food process effacement. Next, please. Okay, this is the proximal tubule. This is there is also powdery deposits in the tubular basement membranes. So these deposits are characteristic of MIDD, monoclonal immunoglobulin deposition disease.
So this is the last picture. So we go to the final diagnosis.
No, I think Dr. Jason should conclude the case, the pathology first.
Okay. So I signed this out as crescentic light chain, heavy chain IgM kappa deposition disease in the setting of small B-cell lymphoma with plasmacytic differentiation. So at the time that they did the biopsy, I already have they already did the bone marrow biopsy. So the pattern of injury was diffuse proliferative and membranous proliferative GN with 81% crescents. EM showed powdery deposits along the GBM and TBM, as well as in the mesangium with reactivity for monotypic IgM kappa. They did SPAP, they did free light chains and came back with monoclonal. Okay, so it's MIDD. There is chronic active tubular nephritis, which is severe, and I think it's related to the MIDD, and maybe the crescentic glomerular injury could contribute to that. There was diffuse acute tubular injury, focal acute tubular necrosis, and there was focal tubularexis. And there's mucoid intimal edema in an interlobular artery, which is suspicious for acute TMA. Right? And there was no other monoclonal gammopathy associated kidney lesions. There was no crystal deposition. And the chronic changes was quite, it's like moderate. It took, so the biopsy, and on the next day they got a call from me. So that was pretty fast.
Okay. So, Dr. Nathapat, so you want to progress the case because the patient became oliguria and uremia after biopsy, and we started HD hemodialysis. So, do you want to progress the case a little bit and also review the complete workup from Dr. Hyan asking you about the free light chain and electrophoresis?
Okay, after we did the biopsies, the patient have had further oliguria and uremia. Then we started dialysis since then, and so now we go for the further investigation that we already sent at the time. The first one is serum protein electrophoresis, which showed monoclonal at the beta 2 and gamma zone, which are quite high here. Is the M protein about 2.07. And the quantitative immunoglobulin showed the IgM markedly elevated at 3,000 against the reference 40 to 230. And another immunoglobulin is quite low. And the serum free light chain showed the kappa at 500 and the lambda is 50. The kappa lambda ratio was about 9.15, which is mark restricted. Moreover, we already did a bone marrow biopsy, which compatible with a small B-cell lymphoma. That is like a lymphoplasmacytic lymphoma. We showed about more than 50% of population have a positive kappa and CD19, CD40. And we also send the MYD88L265P mutation, and the heterozygote mutation was detected, which is one of the supporting clue of Waldenström macroglobulinemia diagnosis. So we have to conclude that this patient had Waldenström's macroglobulinemia with a crescentic glomerulonephritis with glomerular IgM kappa, monoclonal immunoglobulin deposition with a thrombotic microangiopathy. So I go for a mini review of this disease. Before we close, I would like to step back a moment and put the case in the context of wider literature. The Waldenström macroglobulinemia, since that is really systemic disease, underlie everything we just walked through by the criteria summarized in the 5th edition of the WHO classification. Bone marrow infiltration by more than 10%, which is compatible with this case, and together with an immunophenotype that show the positive of CD19, CD20, or IgM, and desirable supportive feature including detection of MYD88 mutation, which is we found. And lastly, serum electrophoresis immunofluorescence show with the presence of monoclonal IgM. So when we have to treat the patient with Waldenström macroglobulinemia, one of that clue and one of that criteria is the nephropathy that is related to the Waldenström macroglobulinemia. So we will focus on that part. About the renal manifestation of Waldenström macroglobulinemia, we have a report by Mr. Salviani and the colleagues in 2014. He reviewed about 32 cases report Waldenström macroglobulinemia. We found that the most presentation is MIDDs with intact immunoglobulin for 46%, and other deposition for 20%. And for the nephrotic form like MCD or MN for 15%. Cash nephropathy is more or less 12%. And our presentation is quite rare among us. Among those part is just 3 cases among 32 cases. So I would like to back to our case. So during the admission, his serum creatinine is rising and clinical uremia. Then we prompt the initiation of hemodialysis, and then he then completed the 6th cycle of rituximab, cyclophosphamide, and prednisolone, which targeting the underlying lymphoplasmacytic clone or treat Waldenström macroglobulinemia. With the treatment, his M protein fell to 0.92 from 2.7, if you remember, and his IgM dropped from 3,000 to 610, which is around 80% reduction. So the hematologist concluded that he had a partial response overall. His hematology teams plan to continue monitoring IgM and M protein levels every 6 months. Unfortunately, his kidney function did not recover, and 3 years after the diagnosis, this is today, he remains on the hemodialysis 3 times a week.
Okay, anyone want to ask questions or comment on the case? Or if anyone see the like a similar case that proteinuria that fool you, please tell us. Okay, no. While waiting for that, so 5 things to carry home. So the first one, in seronegative RPGN over 50. So the paraprotein screen belong with the serology. So I think it's maybe chance to diagnose the case. And the second one, the clue was gamma gaps. Look at it every time. And the third one, immunofluorescence, tell you whose protein it is. electron microscope tell you what the shape it look. In the monoclonal disease, you need both, I think. And the fourth one is the kidney is sometimes the first place a lymphoma announced itself. And the last one is treating the Crohn is not the same as saving the kidney. So I think, and no one, you can text as well. The article or the case is already published in the Gomala disease this year. So please download. I already upload into the chat, so you can download that, and the record go up to on the YouTube shortly, and we will circulate the link across the regions. So before giving turn to Lily, so I would like to thank Adrian. You really made the CPC coming alive. and, also, and also thank Dr. Chilesit and Dr. Thanap, Dr. what is called, Natapat, our second year fellow for bringing the case on the stage. And thank you anyone to join CPC today. Lily, please,
Okay.
and also open the camera, so we're gonna take a photo, a good photo for us. Lily, you can say.
Yes, okay. So I think can take the photo. So thank you very much to the King Chulalongkorn Hospital team, Dr. Natapat, Dr. Jarasid, and Golf for a very interesting but complicated case. So I think we really learned a lot today. For your information, the next webinar will be in October,
Adrian,
27th
please
of
open your
October.
camera as well. No, sorry, to interrupt.
Oh, okay. So the next webinar will be by the Indonesian team on the 27th October. So I hope the Indonesian team who's here today can just discuss with your seniors and who will be presenting. I think that's all. Thank you very much, everyone, and have a very good day. Thank you.